Hi, I'm Mark Sabatine, chair of the TIMI study group. And in this edition of From the Chairman's Corner, I'm delighted to welcome Nick Marston, one of our investigators here. Nick, welcome.
Thank you for having me.
And congrats on a terrific AHA 2025. So you had as a late breaker 2 TIMI trials, CORE2 72a and CORE2 TIMI 72b, a mouthful, but a terrific job in a simultaneous publication in the New England Journal. So congratulations.
Thank you very much.
Really terrific. Help our viewers understand, first of all, so the drug you studied was olezarsen, and tell us a little bit about what the drug is and how it works.
Yeah. So olezarsen is an antisense oligonucleotide that targets apolipoprotein C3 or ApoC3. And that's an important protein in triglyceride metabolism. And the reason for that is, one, it's an inhibitor of lipoprotein lipase, and that's a key enzyme in triglyceride metabolism and breakdown. And the second reason is ApoC3 is an inhibitor of hepatic uptake of these TG-rich lipoproteins. So taken together, if you prevent the ApoC3 protein from being made in the first place with olezarsen, you'll have increased breakdown and increased uptake of these triglyceride-rich lipoproteins, which will lower the triglyceride concentration in the bloodstream.
Great. So it really facilitates the metabolism. So then tell viewers about the population study, because you and one of our other investigators, Brian Bergmark, studied olezarsen in other trials, in Bridge and in Essence, 2 other late-breaking clinical trials and 2 other publications in the New England Journal of Medicine. But this population is a little bit different.
Yeah, that's right. Those were in moderate hypertriglyceridemia, so triglycerides from 150 to 500 milligrams per deciliter. These 2 trials were focused on severe hypertriglyceridemia, so 500 milligrams per deciliter or higher, so a distinct population. And we set a pretty high bar here. These patients had to have triglycerides of 500 or greater at 2 separate time points during the screening period. And that's important because people can have variability in their triglycerides. So we kind of ensured that they were persistently in the severe range, and that's despite really good background therapy. So, these patients were on a lot of statin, over 70% on statins, over 60% on fibrates, and over 30% on icosapent or another omega-3 fatty acid.
All right, so patients with severe hypertriglyceridemia, well-treated, a tough-to-treat condition. All right, so tell us about the primary endpoint, the primary results.
Yeah, so the primary endpoint here was triglyceride lowering at 6 months. It's placebo-adjusted triglyceride lowering at 6 months. And we had 2 doses we were testing, a 50 milligram dose and an 80 milligram dose. And we had 2 trials. So we essentially had 4 primary endpoints. So it's a lot to cover, but the 80 milligram dose in CORE reduced triglycerides by 72%, placebo-adjusted, and the 50 milligram dose by 63%. So these are significant triglyceride-lowering effects, much more than we're seeing with our current therapies, those therapies I just mentioned, which have more modest effects on triglycerides.
Yeah, I mean, that's really quite dramatic.
It is, right? I mean, you think about icosapent, for example, thinking about 20% reduction, fibrates, maybe 30+%. So we're looking at 2 to 3 times more of a reduction. And that leads to more patients kind of getting to goal. And in a severe population, severe HTG population, our goal is really to get them out of the severe range and below 500. And so in 86% of patients with either dose got out of the above 500 range, got out of that severe range. And over a third and over half with the 50 and 80 milligram doses actually achieved normalization of their triglycerides with olezarsen. So not just large reductions, but getting to the targets and goals that we want clinically.
Yeah, that's amazing, not getting them just from severe to moderate, but really normalizing.
Yeah.
So that's tremendous. So you nicely walked us through the really impressive results for triglycerides. As cardiologists, we think a lot about cholesterol.
Yeah.
But there's all different types of cholesterol.
Yeah.
We think mostly about LDL cholesterol, but on triglyceride-rich lipoproteins, and there's remnant cholesterol. So help make sense of all that.
Yeah, no, we think a lot about LDL particles and the cholesterol on that. LDL cholesterol is what we measure. But there's also remnant cholesterol. That's the cholesterol on these other particles, these TG-rich lipoproteins, for example, VLDL, very low density lipoproteins. And so remnant cholesterol and VLDL is thought to be atherogenic just as much as LDL particles and LDL cholesterol. So they are important to lower, but our drugs today focus on LDL lowering and not remnant cholesterol or VLDL lowering. Olezarsen, though, has the opportunity to do that, to kind of meet that unmet need. And so what we see here on the lipid profile is not only are there significant reductions in triglycerides, but the cholesterol in those particles kind of follow suit. They're also significantly reduced by 50 to 70% for remnant cholesterol. And then non-HDL cholesterol, which is kind of our marker of overall atherogenic risk, that's reduced by up to 32%. So we see overall favorable lipid profile in terms of atherogenic risk. And then I'm sure you're going to want to talk about the LDL too, because I think that's a fascinating part of this.
Yeah, because you very nicely covered the percent reductions, but these patients have a sort of a different lipid profile than most of our patients. And so maybe walk us through some of the absolute changes, some examples for that.
So the LDL is interesting. So these patients start quite low. Their LDLs are 60 milligrams per deciliter on average. And the reason for that is part their biology and in part they're very well treated. I mentioned the statin therapy that they're on. So they're starting low at 60. And then this drug, because it takes TG-rich lipoproteins like VLDL and breaks them down into smaller, more dense particles like LDL, you actually somewhat expect a little bit of an increase in LDL. And so we did observe that. So they went from about 60 milligrams per deciliter up to 80 milligrams per deciliter on average, so a 20-point increase. However, that was more than offset by the reduction we saw in remnant cholesterol. So these patients started with high remnant cholesterol, 130 milligrams per deciliter, normal's below 30 or 35. So these are quite high levels. And then with the 50 to 70% reduction, they end up having a reduction, on the order of 80 milligrams per deciliter. So 80 versus 20, non-HDL, the cholesterol is kind of the integrator, and that then comes down with an absolute reduction on the order of 40 points. So
so that's nice. And if Alan Snyderman were joining us, he would say, "What about ApoB?
Yes.
Grand integrator for particle count."
Yes. No, and I agree. ApoB is probably the best measure, and so it is important. It was significantly reduced with olezarsen. So again, showing that we're favoring an atherogenic benefit here, although it was more modest than non-HDL. So with non-HDL, upwards of 30 to 33% reduction at the highest dose. Here we're seeing, 7 to 9% reduction.
Yeah, but still down.
Yeah.
Okay, so that's good for biochemical measures.
Yeah.
But when we think about patients with severe hypertriglyceridemia, we worry about pancreatitis. So tell us about the pancreatitis data.
Yeah, it's exciting because this was, like you said, a lipid lowering trial, not an outcomes trial, but we were able to collect outcomes on this important secondary endpoint, acute pancreatitis. They were adjudicated by a blinded CEC. And what we found was that there was a really substantial reduction in acute pancreatitis. So by moving these patients out of the severe range, we saw an 85% relative risk reduction in acute pancreatitis events. And these are, these can be very life-threatening, honestly. Patients get hospitalized, they can be in the ICU, intubated, and can even cause death. And so to reduce pancreatitis events by that much, I think is really going to be able to change practice and patients' lives who have severe hypertriglyceridemia. So that's the overall pancreatitis finding, which is just really exciting.
No, for sure. I mean, 85% reduction, right, is absolutely tremendous. What I realize the data are sort of relatively hot off the presses. What other insights in terms of subgroups of patients with pancreatitis? What did you see in terms of who was at particularly high risk? Yeah, so we pre-specified a high-risk subgroup, and these are patients with triglycerides that are above 880 milligrams per deciliter, and it's about 10 millimoles per liter for our colleagues in Europe. That is really a risk threshold where we start to see chylomicronemia, which is a driver of acute pancreatitis. So it's a high-risk group. So TG's 880 or higher and prior pancreatitis, so also obviously a big risk factor. And this group had a much higher baseline rate of events. Most of the events were actually in these patients. Yet we still saw an 83% relative risk reduction in acute pancreatitis. So olezarsen was still working to prevent acute pancreatitis in these patients. And because the baseline risk was so high, they had a very large absolute risk reduction. So we're talking about over 30% absolute risk reduction, which came down to a number needed to treat of just 4 patients over 1 year. That is an impressively low number needed to treat. So all that's really terrific for the efficacy. You mentioned this was an antisense oligonucleotide, and just in the field, people have worried about issues for LFTs, for platelet counts. Thrombocytopenia in particular, and potentially for proteinuria. And what did we learn from this data set? Yeah. So for LFTs, we saw that the 80 milligram dose was associated with an increase in transaminases. We did not see that for the 50 milligram dose. And neither dose was associated with higher transaminases above 5 times the upper limit of normal, nor did we see any elevations in bilirubin or any cases of Hy's law.
So that's kind of where things stand for the LFTs. And then for the thrombocytopenia, which had been an issue with the parent compound, it was much less of an issue here. So the 80 milligram dose was associated with mild thrombocytopenia less than 100,000, but that was not seen with the 50 milligram dose. And neither dose had thrombocytopenia below 75,000. So, the parent compound had thrombocytopenia issues that were much lower in a much larger population. So it's a huge improvement in that regard. And then in terms of, renal function and albuminuria, we didn't see any negative effects there, any safety concerns at all.
It looks like those have been then dismissed.
Yeah.
That's very nice.
Yeah.
Now, also in this trial, then you embedded a hepatic fat sub-study.
Yeah.
We know these patients are at risk for having steatosis. So tell us a little bit about that sub-study.
Yeah, we did. We did this initially for safety, but then there was also some data suggesting perhaps we could see efficacy and improvement in hepatic fat here. So we powered a pretty large hepatic fat sub-study. Over 300 patients got their baseline. Less than that got the 12-month follow-up. But among those who had baseline and 12-month hepatic MRIs, we were able to measure the change in their hepatic fat. And there was an increase with olezarsen in kind of a dose-dependent fashion with the 50 and 80 milligram of approximately 2% and 4% point increases. However, that was not associated with increase in transaminases. And so overall, doesn't the clinical meaning of this is unclear. It's an imaging finding at this point, something we're continuing to follow in an open label extension where we'll have hepatic MRIs done at also the 24-month mark and even the 36-month mark.
Yeah, no, thank you for that. And so you nicely then dovetailed into this open label extension. So tell viewers a little bit about that.
Yeah, so open label extension, is something we would like to do in our trials if possible. I think there's a few benefits to this. It can help with recruitment, retention, and also just for patient care longer term, keeping them on, especially a drug like this that lowers acute pancreatitis. So here it's going to be, we're looking at 2 to 3 years of ongoing treatment with these patients. We had huge interest from our patients. About 90% of patients who were eligible wanted to stay in the open label. Everyone's getting the 80 milligram dose. I know I have one patient in particular who's in the open label, and she just swears by this, because she had multiple pancreatitis episodes previously. And has not had any since being the open label extension. So, I think it's an exciting thing for patients and will be a bridge for them until this drug is approved.
Terrific. Well, I think a practice-changing trial. Congrats on that.
Thank you.
All right. Thanks for joining us for this episode of From the Chairman's Corner, and take care.